Bismillah ar-Rahman ar-Rahim. Welcome in this meeting of Egyptian Society of Nephrology and Transplantation, CME chapter meetings. And we are really pleasure today to have one session regarding pregnancy and kidney disease for women and kidney disease. And of course, we have three women in this meeting. And I am really pleasure to have Professor Rasha Samir as the moderator of this session. Professor Rasha, she is known, very known about her interest in this field of nephrology, this very practical and important field of nephrology, women kidney disease, and she is one of the founders of
يعني بعد هنا عشان على مكتوب 38 ياسين بعدها
and she is one of the members of Women in Nephrology working group of ISN, International Society of Nephrology, and African Association of Nephrology. Of course, she is an associate professor in nephrology and medicine in Mansoura University, one of the very active members. And today we have two of her colleagues to present this session in a case discussion manner. DrAmany Makrom, lecturer of gynecology in Mansoura University, obstetrics, of course, and gynecology in Mansoura University, and DrDalia Yonis, lecturer of nephrology and medicine in Mansoura University. I will leave the floor to Dr. Rasha to further introduce her colleagues before case presentation. And I would like to thank my colleague, Dr. Abdulrahman El-Maghrabi, for all of his work, lecturer of medicine and nephrology in Cairo University, who is the coordinator of this meeting, and for all of his work regarding CME chapter meeting activities. So please, Dr. Rasha, start.
Thank you so much, Dr. Yasser, for the kind introduction. And thanks for inviting us to this webinar. Today I'm pleased to join the webinar with two of my colleagues in Mansoura working in obstetric nephrology for several years. And we are discussing two cases. The topic of these two cases would be proteinuria in pregnancy, proteinuria and hypertension in pregnancy in particular, and the differential diagnosis and how to approach these cases. We'll start the first case with Dr. DrAmany Makrom. She's a lecturer of obstetric and gynecology at Mansoura University, and she's one of the best obstetrician and best team players I have ever met. Dr. DrAmany, please go ahead and start your presentation.
Thank you, Dr. Rasha. It's a great honor to be with you today. My presentation is about proteinuria in pregnancy, the debate case presentation. We had a case which is primary gravida, age 26 years, housewife, married for 6 years, with no special habits of medical importance. She presented to our emergency department at 20th week gestational age with slight dizziness and edema both lower lip. In examination, we found that the blood pressure was 190/110 and proteinuria was 4+. The patient had her story started 7 days back at 19 weeks gestational age before she presented to us, when she developed bilateral lower limb edema. Then there was rising of blood pressure and appearance of proteinuria. Hypertension with pregnancy. Hypertensive disorders of pregnancy is one of the leading causes of maternal and perinatal mortality worldwide. Preeclampsia complicate 2 to 8% of pregnancies globally. Clinical presentation similar to preeclampsia, but at gestational age earlier than 20 weeks. We have to think about alternative diagnosis, including thrombotic thrombocytopenic purpura, maybe hemolytic uremic syndrome, maybe renal disease, or autoimmune disease. Our patient had a history of primary infertility for 6 years. She had underwent 6 hysteroscopy and 1 laparoscopy and multiple trials of superovulation. On investigation for infertility, she was found to have hypothyroidism and she started L-Trexin treatment. She underwent multiple times of controlled ovarian hyperstimulation and embryo transfer for 7 times, fresh and frozen embryos, but unfortunately all were unsuccessful trials. This was her first successful pregnancy from the 8th IVF and embryo transfer trial. On doing the investigation for this patient, all were revealed to be normal, except that she had slight hypoalbuminemia, serum albumin was 2.7 gram per deciliter. And these investigations were repeated during admission period for follow-up and detection of any deviation from normal, but no major changes were found. Creatinine clearance was found to be 127, and 24-hour urine total protein collection was found 2,250. Albumin creatinine ratio was 8,297. About nephrotic range proteinuria is urinary loss of 3 gram or more of protein per 24 hour or 2 gram of protein per gram of urinary creatinine on a single spot urine sample. It complicates 0.32% of pregnancies, of which preeclampsia contribute to 0.19%. Another investigation was done: anti-nuclear antibody, anti-double strand antibody, anti-neutrophil cytoplasmic antibody, and all were negative. HBs antigen, anti-HCV, and HIV negative, complement 3 and 4 and rheumatoid factor were negative, immunoglobulin E and thrombin 3 negative. Renal ultrasound have shown that both kidney average parenchymal echogenicity, preserved corticomedullary differentiation, no stones or back pressure, urinary bladder was empty at the time of examination, and no detected free float. No history suggestive of systemic lupus regarding the patient, and no family history of any renal problem. The fetal condition on admission: doing a transabdominal sonography had shown a single living fetus with biometry corresponding to the gestational age 20 weeks, and adequate amount of liquor and good fetal movement. The baby was going well. Medications: so she was taking antihypertensive, 3 types of antihypertensive medications: Aldomit, epilat retard, and Lavipres. And albumin transfusion was also recommended for the patient, and Kilixin. That was a confusing case. Nephrotic syndrome or preeclampsia. It can be difficult to differentiate intrinsic renal disease causing nephrotic syndrome from preeclampsia, particularly after 20 weeks of gestation. Our nephrology colleagues planned for renal biopsy. However, the patient developed moderate ascites, so the renal biopsy was not done, and she also developed mild pleural effusion during the follow-up period. So now we have a patient, 26 years old, primary gravida, pregnant 22 weeks by ICSI, hypertension with nephrotic range proteinuria, hypothyroidism, history of primary infertility 6 years, history of 7 failed ICSI. Patient had edema all over the body with puffy eyelids, which was improving during the admission period, moderate amount of ascites, which was also improving, and mild pleural effusion. Her precious baby was going well. However, the umbilical artery Doppler had started to be affected. She is taking 3 antihypertensive medications. She is taking Eltroxin. She is taking low-dose aspirin, Kilixin, Suloprid, and cyclosporin and Lasix. The MDT decision was to continue the pregnancy with close monitoring of the maternal and fetal condition, continue the previously prescribed medication. Renal biopsy will be postponed till the termination of pregnancy, and doing SFLT1 and PLGF. This special investigation was done, and that was the result. SFLT was 26,000, more than 26,000, and PLGF was less than 10, and the ratio was 2,660. These are pro-angiogenic and angiogenic factor altered in pregnancies complicated by placenta-related disorder like preeclampsia. Preeclampsia is a complex disorder characterized by poor placental function and maternal endothelial dysfunction. This ratio leads to insufficient remodeling of maternal spiral arteries and placental skin. Soluble FMS like tyrosine kinase 1. In normal pregnancy, concentration increased during the 3rd trimester, but increased prematurely in preeclampsia. Circulating maternal SFLT1 increased approximately 5 weeks before the onset of symptoms. Placental growth factor enhances the action of vascular endothelial growth factor A, essential for placental vascular development. Increase initially, peak in the mid-gestation, and then gradually decrease toward term. This decrease in placental growth factor occurs prematurely in preeclampsia. Lower maternal level of 80 to 120 are able to diagnose preeclampsia in asymptomatic woman. The ratio: high SFL1 secreted by the placenta to promote peripheral vasoconstriction, raise maternal blood pressure, increasing the flow of oxygenated blood through the intervillous space. Consequently, concentration of pro-angiogenic factor, placental growth factor, are reduced due to inhibition by SFLT1. Increasing SFLT1 and decreasing placental growth factor result in an increasing of the ratio. Ratio less than 33, rule out preeclampsia. Ratio more than 110, diagnose preeclampsia. Our ratio was less than 10. Our ratio was more than 2,000. During the follow-up of the patient, unfortunately, intrauterine fetal death happened at the age of 24 weeks, and medical induction of abortion was done. The patient was discharged after evacuation of pregnancy, and with strict advice and recommendation for follow-up regarding the high blood pressure and the disturbed kidney function with our nephrology colleagues. After termination of the pregnancy, surprisingly, the patient had shown marvelous improvement after termination of her pregnancy, and all kidney function were normalized. Partial improvement after 2 weeks and complete improvement after 4 weeks. And renal biopsy was not required anymore. The laboratory investigation were normal, and serum albumin was shown to be improving 4.2. The most surprising was the protein create ratio, which was normalized 123. Placental growth factor, SFLT1, and the ratio are useful for screening, diagnosing, predicting, and monitoring placenta-related disease in pregnancy like preeclampsia, and decision-making about optimal time for delivery. Combining clinical risk factor, maternal blood pressure, uterine artery pulsatility index, and maternal angiogenic biomarker in an algorithm may be a more accurate way of identifying high-risk women. What's next for this patient? Should we do SFLT-BLGF ratio in each pregnancy for this patient later on? Should we start low-dose aspirin at an earlier gestational age for like this patient? Is it safe for this patient to do IVF in the future? Is there any future risk of renal problem for this patient? Thank you.
Thank you so
thank you.
much. اتفضل.
Dr.
اتفضلي يا
Yasser.
دكتورة.
Thank you so much, Dr. Amani, for presenting this case. And I think it's a kind of what we think the atypical presentation, or what's not behind the common presentation. Because this patient presented with nephrotic range proteinuria, her urinary protein, 24-hour urinary protein was around 12 grams, as the patient had features of nephrotic syndrome with hypoalbuminemia and edema. So she also had her presentation just a few days, or let's say 1 week before the 20th week. So we were likely proposing a glomerular affection or a picture of nephrotic syndrome due to glomerulonephritis rather than in particular preeclampsia. I think in this case, the SFLT placental growth factor very high ratio, which exceeded the 2,800, I think, came suggestive of preeclampsia. But however, we're still convinced that this patient was not a case of preeclampsia, and the patient had rather a picture of nephrotic syndrome due to glomerular affection. But the long-term follow-up of the case that showed improvement, full improvement over 6 weeks postpartum, with normalization of urinary protein, normalization of the blood pressure, normalization of serum albumin, and all the other abnormalities, maybe with the sad occurrence of the intrauterine fetal death within a few days just after this lab has been done, rather made the diagnosis of preeclampsia more likely. So let us see the questions and the comments if you have any.
Is it usual to have preeclampsia? This is huge nephrotic range proteinuria in preeclamptic cases, Dr. Rasha?
As I just said, Dr. Yasser, thank you for the question. It is not the typical presentation of preeclampsia. Preeclampsia is known typically to present by non-nephrotic range proteinuria. In most cases, present 100 proteinuria, but this patient presented with 12-gram protein. So we thought first that this patient had nephrotic syndrome due to whatever cause. So we started to do the serologic workup and search for maybe a cause of this nephrotic syndrome. But the long-term follow-up, the complete resolution, the laboratory value of the SFLT placental growth factor ratio came all supportive of preeclampsia rather than other diagnoses.
Of course, totally agree with you that it after the course revealed that it is preeclampsia, but I think that, as you said, it is not that the common presentation. Did you think of biopsy at any stage immediately after delivery, for example?
We sought to do, we considered kidney biopsy at the time the patient presented with a nephrotic range proteinuria and nephrotic syndrome. This was
Yes.
around 20 gestation, but as Dr. Amani said, the patient had ascites, and so we postponed biopsy to control the ascites the patient presented with. The course rapidly evolved, and the patient had intrauterine fetal death, and after termination, she completely improved. So there was no need for biopsy later on.
The improvement was that rapid that you didn't need a biopsy or didn't think for a biopsy at all, huh?
We didn't think for a biopsy postpartum, but we thought of biopsy at time of presentation at 20-week gestation.
I'm asking postpartum.
No.
Professor Hisham, please. Professor Hisham. Professor Hisham, unmute yourself.
Thank you very much. I was muted and I was talking to the globe. So thank you again. I'm jumping on a case on the middle, so I'm not aware about that from the start. But thank you again for these very interesting cases. I think for nephrotic range proteinuria, we have to do non-invasive measurements just to have. So I'm asking, this case, I would like to ask for anti-PLAR2 first.
Yeah,
so,
her age.
Yes, thank you for the comment. We already did the anti-PLAR testing, but had the result after the patient had intrauterine fetal death, and it came negative.
So that's good that we are searching, as Professor Yasser said, that it's completely unusual to have an eclampsia or preeclampsia associated with heavy proteinuria, but it happens.
My question is related. Do you think, Professor Rasha, that it is related somewhat to the way of pregnancy for this patient, IVF or something like this? Is there any report about this?
I think recurrence of preeclampsia will not be so common in this patient unless she has primary glomerular disorders. Maybe she relapsed. In all cases, we have to wait for observations for long term, maybe 1 year, to follow up the patient. If any abnormal urinary sediments, we have to look for renal biopsy before deciding for conception. The problem now is what type of conception. The contraceptive devices or hormonal may aggravate the conditions, but we have to look for that after a year starting from now before providing our consensus toward next pregnancy.
Yeah, but as we know, these patients had primary infertility and had 8 trials of in vitro fertilization. So I'd like to ask Dr. Amani about your protocol in such a case. You have a case with primary infertility, multiple trials of in vitro fertilization and ovulation induction. And another question regarding the link between the complication that happened in this patient and the atypical presentation of preeclampsia, and the probability of being linked to the ovarian hyperstimulation or ovarian induction and IVF therapies.
Actually, this patient had something different. She had multiple trials of ovulation induction and embryo transfer, and I think the last one was through frozen embryo transfer. I mean, not all the time she is transferring fresh embryos. I mean, not all the time are preceded by ovarian stimulation. So now maybe if we transfer frozen embryo, it's something not related, it's away from the ovarian stimulation. So it will affect also or no? The last one where the patient got pregnant, it was through frozen embryos, so it was not just following ovarian stimulation. I'm not sure yet if she tried for the next time and she transferred the fresh embryo. If that will aggravate her condition or will make her more susceptible for another attack of preeclampsia or nephrotic range proteinuria with hypertension or something like that. So I need to know whether we can proceed with her because you know, she's primary infertility, and I think pregnancy is something precious for her, and each baby will be precious for her.
We don't have the choice to proceed with her. يعني she wants to get pregnant again, and she will try to do anyhow.
Yeah.
We had the
It's just the timing, yes. Yes, we are sure that she would try once and twice and thrice, and she has her babies on the plate on the lab, so we cannot avoid that implementing secondary for pregnancy chance. However, we have to be sure that it should be continued. So I think we have to have a holiday from that issue for at least 6 months as in patient with lupus and close monitoring first.
She's her proteinuria is now I think about
Yeah, but may relapse. But may relapse.
1 2 3.
yes,
What?
proteinuria is normalized, but the patient didn't have lupus. She had no medical history prior to this presentation. And we had an observation of a series of cases who underwent in vitro fertilization or ICSI fertilization, presenting with a typical presentation of preeclampsia, maybe earlier than the expected date at the 20th week, or maybe with more heavy proteinuria or more severe presentation. So maybe there is a relation between the method of conception and the patient presentation, maybe.
I think Professor Rasha and DrAmany that preeclampsia itself carries the risk of preeclampsia in the next pregnancy.
Yeah, that's right.
Itself, away from IVF or embryo transfer or something like this
Yes.
presentation, it itself carries the risk of recurrence in the next pregnancy, one of the risk factors.
Yes.
May I ask a question just to my mind? That the patient anatomical uterine ischemic uterine arteries or something like that, making her infertile, so subsequently will be proposed for next time of also preeclampsia. I don't know, but we have to consult a gynecologist about that issue.
So, Dr. Amani, would you like to comment on this question?
Sorry, do you mean, Professor, about the relation about the cause of infertility to preeclampsia?
I'm just joining the rings together to have a view of full view. The patient has infertility. I don't know why she has infertility. Maybe anatomical abnormality, maybe endometriosis, maybe additional factors. So we have to conceive that picture all in one and asking gynecology about the anatomical, blood flow to the uterine in normal states, all of that.
Yeah, I got it. Actually, for this patient, we don't have much information about the infertility history or all that we have about the investigations that she did was hypothyroidism that was discovered during her infertility workup. Actually, the results, she has done hysteroscopy and laparoscopy before, and actually the result was not available for us. But yeah, we have to consider about the uterine pathology or something. Maybe it's related to our condition.
I think so, yes.
Yeah, thank you.
Dr. Amani, here comes a common question, and I see it in the chat as well. The utility of placental Doppler to execute preeclampsia.
Actually, this was about at the end. we are recommending that combining the clinical factor and the maternal blood pressure and the uterine artery plus the biomarker will make more benefit for diagnosing preeclampsia for better diagnosis. Maybe because this patient presented at 20 weeks, so we have done just only umbilical artery Doppler for only the patient for confirming the viability or the state of her baby. But we didn't do uterine artery, but of course it's of benefit.
I see in the chat a question regarding the use of salicylic acid or aspirin for preeclampsia prophylaxis.
Yeah.
Yeah, I think it's one of the points that have solid evidence in the literature regarding the use of aspirin for prophylaxis of preeclampsia, and this typical dose around 75 milligram per day. It should be used for all CKD patients, for all patients who have risk with GN and renal patients, and also for patients who have risk for preeclampsia if they are not renal patients, right? Yeah.
Yes.
For the SF80 placental growth factor, it's unfortunately not available in Egypt. So we did this outside Egypt, and we see that it was helpful in making diagnosis that was confirmed later postpartum. So I hope, considering the low cost of the test, that it will be available in the coming days. As for biopsy, I see question 2. Yeah, we consider the biopsy at time of presentation when the patient presented with nephrotic syndrome, but we're not able to do. So postpartum, biopsy was no longer needed because the patient had complete resolution of her renal condition. Can recurrent ovarian hyperstimulation syndrome affect kidneys? So I come to DrAmany first for this question.
Actually, ovarian hyperstimulation, not only ovarian stimulation. We are talking about ovarian hyperstimulation, which is a side effect of the normal ovarian stimulation. So it has affection in severe cases. It has an effect on the kidney. So maybe this patient was exposed to at one time for ovarian hyperstimulation, and maybe she had kidney insult at that time. Maybe, but yeah, there is cases of severe ovarian hyperstimulation where it affected the kidney.
So regarding the use of immune suppression in this case, it was empirically given to the patient based on diagnosis of nephrotic syndrome, which was proven later to be preeclampsia, not typically glomerulonephritis. So this decision was later revised and immune suppression were definitely withdrawn. There is a question, DrAmany, regarding the protocol of use of Kilixane anticoagulation and salicylic acid in patients who undergo IVF. Is this a standard protocol?
Actually, there is a difference in Egypt between the standard or the guidelines and between what is used to be done for the patient. So actually, in these patients with multiple trials of ICSI and failure of implantation or something, so we used to do to give the patient Kilixane and Asposite. But actually, in this patient, she was taking Kilixane, but Asposite was not given to her except after she developed hypertension. I think she had to start Asposite even earlier before that age, that gestational age.
Yes, fully agree. Dr. Yasser and Dr. Hisham, I see multiple questions regarding kidney biopsy and immune suppression. Considering that this patient had her kidney function completely normalized after termination of pregnancy, would you go for any kidney biopsy or further immune suppression for this patient?
For myself, no, I wouldn't go through except just monitoring if recurrence of proteinuria or any abnormal hematuria, I would go. Otherwise, just wait and see.
For me, I will not go for any biopsy. I don't think that we will find any significant findings. My question was that immediate postpartum, that we can have some findings regarding the original pathology, but now the patient is totally normal or near normal, do not think even will be medical legally, only from academic reasons. And I don't think that will have any significant finding in this biopsy. There is some lesion that is related to the condition and can recur once the condition recurred, but it is not that continuous process throughout life or continuous pathological process. It's related to the pregnancy and its condition.
We agree. On a theoretical basis, it has been revealed that some women with preeclampsia, despite complete clinical improvement, still have pathological abnormalities in the kidney biopsy till 2 years postpartum. But in this case in particular, I have no urinary abnormalities. I have no abnormalities in kidney function, in urinary protein excretion. The blood pressure is normal. So I don't think to have a rationale to do kidney biopsy for this patient, as Dr. Hisham and Dr. Yasser said.
I think, Dr. Rasha, that it is similar to cyclosporin or CNIs in transplant. If you do a biopsy, you will find some changes, but will you treat only these changes or something like this? You diagnose the case as preeclampsia, and if you find a preeclampsia on biopsy, will not be strange. Will the biopsy answer your question regarding this point? I don't think. Even if you found some remaining changes in the biopsy.
Yes.
Mm.
I think no more questions in the chat.
We can move. Okay.
I'd ask Dr. Amani for the presentation and invite.
تفضلي.
It's a pleasure to introduce Yonis. She's a lecturer in nephrology at Muslim University, and she's active part of the nephrology team for 5 years. She's going to present a case in pregnancy. The case for a French woman who had been treated in France during her first pregnancy and then got married to an Egyptian man and came to Egypt during her second pregnancy. Please go ahead and state your case.
Thank you, Dr. Rasha, and welcome all attendees of my professors and colleagues. It's my pleasure today to present this case with hypertension and proteinuria in pregnancy. Our case today is a 17-year-old woman with a past history of 2 miscarriages and 1 non-complicated pregnancy. She had no history of comorbidities or autoimmune disease. The story started at 23 weeks of gestation when the obstetric ultrasound revealed severe fetal malformations in the form of a single ventricle with pericardial effusion, ascites, and intestinal hyperechogenicity of the fetus. After discussion with the patient and her husband had decided to continue the pregnancy. Unfortunately, as the pregnancy progressed and at the 30 weeks of gestation, the patient started to develop hypertension, proteinuria, oliguria, and massive edema with weight gain of about 17 kilograms, which indicated at that time hospital admission of the patient. The first laboratory investigation after the admission showed anemia with hemoglobin 8.3 without evidence of hemolysis, normal serum creatinine and normal liver enzymes, severe hypoalbuminemia with serum albumin 1.8 gram per deciliter, and proteinuria about 2 gram per 24 hours. After 2 days of admission, the patient showed difficulty in control of the blood pressure and the resistance of oliguria, so that cesarean delivery was performed with delivering of a stillborn baby weighing about 3 kilograms. And this arises a question, would diagnosing this case as preeclampsia be misleading, and what can explain the stillborn anasarca and weight gain of about 17 kilograms of the mother? In fact, the scenario of this case started in Lomans Hospital in France under the supervision of Professor Georgina Piccoli, which is a pioneer professor in the field of obstetric nephrology. And this case at that time was diagnosed as what is called the maternal mirror syndrome, This syndrome was first described in 1892 by John William Ballanite, professor, and after that time it was known by various names, including Ballanite syndrome, maternal hydrops, pseudotoxemia, or triple edema syndrome. And there is a diagnostic criteria that can help in diagnosis of this syndrome. It includes a triple edema of the placenta, fetus, and the mother. The placentomegaly is defined as placental thickness more than 4 centimeters in the first half of gestation or 6 centimeters in the second half of gestation. Fetal hydrops which need accumulation of fluid in 2 or more fetal compartments with predominance of the peritoneal cavity in those cases, and a clinical detection of maternal edema. And the naming of this syndrome as mirror syndrome came from the fact that the maternal edema mirrors the fetal and placental edema. Actually, the preeclampsia and the mirror syndrome share a common clinical manifestations, including the maternal edema and hypertension, but the available literature suggests that mirror syndrome can be differentiated from preeclampsia by its early onset and the presence of hemodilution, which is a sharp contrast to hemoconcentration that is present in preeclampsia. This is the first systematic review to describe a number of cases with maternal mirror syndrome. This systematic review was published in 2010, and it included about 50 cases. And this systematic review showed the ultrasonographic finding of fetal hydrops in the form of ascites, like in this case, and the subcutaneous edema. Also, it started to describe a number of fetal anomalies that were hypothesized to be triggers for the development of this syndrome. And the most common fetal anomaly described in this systematic review was the cardiac congenital anomalies. This is the second systematic review that described about 100 cases published in 2016. And this systematic review continued to describe other fetal anomalies to be triggers for this syndrome, like fetal anemia, Rh isoimmunization, twin-to-twin transfusion, or fetal viral infections. And we can see that the peak of gestational age at diagnosis of those cases was at 27 weeks of gestation. Also, we can see that the maternal weight gain and edema was the most common maternal finding. And also there was oliguria in about 15% of cases, and fetal hydrops was the most common fetal finding. And unfortunately, the overall survival rate of the affected fetuses in those cases was only 1/3 of the cases. In addition to the conservative management of those cases, there is a recently published article talk about a number of promising fetal interventions that can be done before delivery, and it can result in antenatal resolution of the maternal hydrops and the maternal mirror syndrome, which can result in a good impact on the birth weight and gestational age at delivery for the resolved cases. Those interventions included pleuroamniotic shunt for some cases with fetal hydrothorax, and maybe a placental ablation for cases of twin-to-twin transfusion, and maybe intrauterine transfusion for cases of fetal anemia as triggers for the development of this syndrome. But actually, it seems that the placenta always play the main player in this field of obstetric nephrology, like preeclampsia. The evidence of that is the change in the serum level of placental growth factor and soluble FMS like tyrosine kinase 1, like the changes that occur in preeclampsia. There is a detection of increase in soluble FMS like tyrosine kinase 1 in those cases, and a decrease in the placental growth factor, which result in increase in the ratio. But the difference is maybe that the increase in the ratio is to lesser extent in the cases of maternal mirror syndrome in comparison with preeclampsia, because of the placental edema and the placentomegaly in those cases, which is a source of the placental growth factor, which result in less decrease in the placental growth factor, so that the increase in the ratio is to lesser extent in those cases in comparison with preeclampsia. And back to our case, and a good news about this case that she is presented to us in her next pregnancy in Mansoura obstetric nephrology service for follow-up of her next pregnancy. And the pregnancy continued successfully without any complications. And this is the good news for this patient. Thank you.
Thank you so much. اتفضلي يا دكتور.
I'm going to summarize.
Dr. Rasha, thank you, Dr. Amani, for this very interesting case. And even internationally managed this case in conjugation with Mansoura obstetric nephrology clinic. I have a question that is maternal proteinuria and edema is a must in this syndrome? You said that the trigger can be congenital anomalies or something related to the fetus. Proteinuria and maternal edema is fixed in this syndrome?
Yes, it's one of the diagnostic criteria of the syndrome. It's a triple edema of maternal, fetal, and placental edema.
Fetal and placental edema.
Yes.
So which of which to start first, or which of which is the initiator? Is it the congenital anomaly or something like the fetus initiated the fetus edema, then the maternal, or something in the mother like preeclampsia or GN or something like this, and is reflected on the fetus?
The exact pathogenesis of those cases is not fully discovered, but it seems that the story started from the fetus due to the detection of multiple fetal anomalies in those cases, and the most common one was the cardiac congenital anomalies. And also the placenta play a main role in the pathogenesis, but it seems that the condition started, or the story started from the fetus and the placenta, not the mother.
The story starts from the fetus. So the edema and swelling of the fetus, hydramnios, etc. It starts first, and then the mother nephrotic syndrome or the generalized anasarca.
Clinical detection, yes, of maternal edema.
Okay. Professor Hisham Said is commenting that her serum albumin is very low. So please, if you have a comment, Professor Hisham.
Mainly due to the hemodilution, not the heavy proteinuria, because this syndrome is characterized by hemodilution, which is different from hemoconcentration in the cases of preeclampsia.
Hemodilution to give this very low albumin?
Hemodilution mainly because in this case the proteinuria was only 2 grams per 24 hours. And the hemodilution is one of the characteristics of this syndrome, and one of the clinical manifestation that can be used for differentiation between mirror syndrome and preeclampsia.
I think Professor Yasser and Dr. Dalia, it's completely unlikely that to have such a very low serum albumin simply from hemodilution. By hemodilution, you meaning that it's, I think I have to put hypervolemia versus volume overload state. The patient has no hypervolemia because intravascular compartment may be shrinking even. So dilutional effect will be misleading for the serum albumin. Considering liver production of albumin or leaky gut from other causes, or albumin escape phenomena from the intravascular compartment could be a rule. However, simply volume status will not explain such a very low albumin cells.
Totally agree with you, Professor Hisham, that hemodilution cannot explain solely the very low
She is
albumin.
not hypervolemic. She is volume overload, and there's a difference between two statements. Hypervolemia meaning increased intravascular compartment, dilution effect of albumin, plus increase of the transcapillary pressure, making albumin leaky from the intravascular compartment. But this patient is not hypervolemic, it's a volume overload.
I think the key message behind this case, thank you, Dr. Hisham and Dr. Yasser, that when we have a patient presenting at 13th week, I mean, after the 20th week, we're in the second half of pregnancy, presenting with hypertension and proteinuria, we'll go for preeclampsia as the most probable diagnosis, as we may consider other glomerular disorders or renal disease. But sometimes some atypical disorders should be considered to like Behr syndrome and other conditions.
Professor Manali Deeb is asking for the mic.
مساء الخير. مساء الخير دكتور هشام، ازي حضرتك؟ ودكتور ياسر، وشكرا على الحالات الجميله يا دكتور رشا. كنت بس عندي كومنت على السيرم البومين. هو حضرتك موجود في كتب الكلينيكال باثولوجي، هو النورمال السيرم البومين بيبقى نورمال في الفيرست ترايمستر، في السكند ترايمستر بيبقى 3.2 جرام، في الثيرد ترايمستر بيبقى 2.8 جرام، وده مكتوبه اللي قالوا يعني فعلا بيبقى فيه هيمودايليوشن وبيأفكت السيرم البوم نورمال، لان كان في عينه عند كده مريضه جات لنا قبل كده في البطنه مورمه على الاخر والليفر كان كويس وعملنا لها بروتين في اليورين كان نورمال، رجعت تاني السيرم البومين لقيته فيه اختلافات في الثلاثه ترايمستر، اول ترايمستر نورمال، تاني 3.2، الثيرد ترايمستر 2.8، ده نورمال في البريجنسي.
انا مش عارف يا دكتوره منال، مش هقدر اقول لحضرتك لان ما قريتهاش كده يعني.
دكتور رشا can you comment please؟
لا في كتاب الكلينيكال باثولوجي.
اوكي دكتوره منال، you are right I didn't read about that.
اوكي
شكرا.
اوكي ثانك يو دكتوره منال. دكتوره رشا you have no comments still now. طيب treatment you said دكتوره داليا many forms of treatment. I think they are directed towards every single lesion of this syndrome. But if you have
conservative management like pre-eclampsia, antihypertensive medications, anti-proteinuric, and maybe in some cases termination of pregnancy.
Yes, this is my question. You said that you can do some things, many things to the fetus to correct for abnormalities present. But if we have multiple abnormalities regarding this syndrome, not single or two abnormality, when you would consider termination of pregnancy in this syndrome?
Termination of
ask the obstetrician what do you actually do in such a case.
DrAmany? Obstetrician will say the usual word. Give us the instruction to terminate, and we will do it. Just do it. I think this is the usual with obstetrician.
Mother safety first. Yeah. If there is something, I think if there is something hazardous to the mother, and termination of pregnancy will be better for her status, so we will do termination of this pregnancy. And it depends. And it depends on counseling the patient and her acceptance also.
So according to the severity of affection of the mother, you will consider this termination.
Yes. And diagnosed with this syndrome early in second half of in France, and she was counseled.
هو الصوت بيقطع يا دكتور رشا، احنا مش سامعين كويس قوي. انا بالنسبه لي انا على الاقل.
I'm sorry. I said that this patient, when was diagnosed with this syndrome in the second half of pregnancy, she was in France and she was counseled on termination of pregnancy, but the patient refused to go. The patient and her husband refused termination. She decided to continue.
She decided to continue. Okay. And the risk of recurrence, you said that in her next pregnancy, it's completely normal, and past the pregnancy, not completely normal. Is there reported risk of recurrence in this syndrome?
No, there is no reported risk of recurrence in the literature.
Okay. Thank you so much for this very interesting case. And I think we have no comments and no questions. And can we close the session, please, Dr. Rasha? Thank you.
Thank you so much, Dr. Thank you for the speakers, DrAmany, Yonis, for sharing their thoughts. And I hope you have been interested. And thank you.
Thank you so much, Mansoura Obstetric Nephrology team, and the lead of eminent Professor Rasha Samir or Rasha Shwiz. Thank you, Dr. Dalia, Yonis, and Makrom for this very interesting session and these very interesting cases, and your success in management of the mother in 2 cases and passing into hopefully for the first one to the successful next pregnancy and the second mother for her successful second pregnancy. And thank you so much, and thank you for all professors who shared and all of attendees for their active share, and again Dr. Abdurrahman Maghrabi for being the coordinator of this session. Excuse me to close. تصبحوا على خير. السلام عليكم ورحمة الله وبركاته. شكرا جزيلا.
شكرا.